Welcome to Recognition Health webinar on how to spot the early signs of Alzheimer's. I'm George Robinson. I'm delighted to introduce today's educational webinar hosted by Recognition Health during Dementia Action. Recognition Health's award-winning team, UK and USA experts specialise in diagnosing and treating conditions affecting our brain and minds at all ages. Recognition Health is a world leader in providing individuals with MCI and Alzheimer's disease the opportunity to join international clinical trials to gain early access to new generation medications designed to slow or ideally halt the progression of memory and related cognitive symptoms. Our team are passionate about education and believe in an early and accurate diagnosis for all conditions affecting the brain and mind. I'm delighted today to introduce Dr. Emer MacSweeney, founder, CEO, and consultant neuroradiologist at Recognition Health, who will be presenting the webinar today. Thank you for joining, Dr. MacSweeney.
Hi, everybody. It's a real honour to present today during Dementia Action Week. At Recognition Health, we really are all about action, and we believe very much that when you are faced with an Alzheimer's diagnosis, or even concerned that this may be a potential diagnosis, it's important to take immediate action and to get access to the best treatment and care as soon as possible. Today, I'm going to talk about not just the early signs of Alzheimer's disease, but also what we do understand about the causes of Alzheimer's disease, and in particular, the research that's underway now to try to both find a means for an accurate and early diagnosis, but also access to new generation medications, which are designed to actually slow down or ideally halt progression of this disease. At the end of the presentation, which will be about an hour, then we will have a session on questions and answers. I'll be very happy to even answer any questions after the formal session as well. So to get started, sorry, can't move my slides forward. There we go. So really the focus today is going to be on prevention of Alzheimer's disease, because ultimately that has to be the way forward, as with any diseases. And in order to prevent a disease, we have to understand what causes it, how to detect it as early as possible, and to find treatments which are effective when given very early. So where are we with Alzheimer's disease? So a national survey that we actually did at Recognition Health a few years ago for people aged 55 and over gave the same results as numerous studies that have been done across the world for this disease. And essentially they're summed up by these statements here. So adults over the age of 55 are most concerned about developing Alzheimer's dementia in their life. So 38% are concerned about getting this diagnosis as opposed to any other diagnosis. And that compares with 26% concerned they'll get cancer and 6% concerned about getting heart disease and stroke combined. Now, the real difficulty is about 81% of people do recognise that difficulty remembering recent events, so in other words, short-term memory, is an early symptom of dementia, and particularly in association with Alzheimer's. But unfortunately, awareness of other symptoms is incredibly poor. And this is actually the best place to start, because this is the first hurdle that needs to be overcome in order to change the future for Alzheimer's. So where are we in 2021? Alzheimer's disease, rather alarmingly, is the only leading cause of death that is still on the rise. In 2018, Alzheimer's disease was recognized by WHO as a global pandemic. So like most things, you wait ages for something and then two come along at once. So we've got global pandemic with COVID, but actually also with Alzheimer's disease. Also, an alarming fact is that there is no treatment available worldwide that can change the course of this disease today. Early diagnosis is difficult, as we've mentioned, and there has been historically a little bit of a delay in focusing funding into research for new medications to effectively treat this condition. But fortunately, over the last certainly 5, but actually probably the last 5 to 10 years, there have been big changes made in this field, particularly in scientific focus and in funding. And the brain has really been one of the most difficult areas for research, but now it's very much a focus of attention. So I think it's really fair to say, and I hope you'll agree with me by the time we get to the end of this presentation, is that today there is reason to be cautiously optimistic about the treatment for this condition. So the medical focus, currently, it's really on identifying symptoms of the condition as early as possible. And it's then recognizing those symptoms once identified, finding simple tests to make an early diagnosis, but also invoking specific biomarkers for very early and accurate diagnosis. And then obviously, and this will be the theme through the presentation, that once diagnosed, we need to have new treatments which will ideally slow down or ideally halt further progression of the disease. So recognizing signs of cognitive impairment, this is one of those things that at one level is very easy and obvious, but another level has been proven to be inordinately difficult. So the problem is it's really just all aspects of our thinking ability. Short-term memory, as we said, is the one facet of our cognition that people are most aware of as an early presenting sign for Alzheimer's. But actually, it's all sorts of other things as well. It's abstract thought, calculation ability, visuospatial skills, so like getting lost in a familiar environment, concentration, speech and language, and then this whole sort of thing called executive function, which is everything from our ability for planning, judgment, concentration, problem solving, all of those sorts of like higher mental function that we do every day. Now, one of the other things that makes it difficult is that those particular symptoms are common to a host of different conditions, different medical conditions. And this slide here is not for the purpose of reading. It's really just to say that when you do present with these type of symptoms that we just saw on the last PowerPoint, the cause for those can be a wide band of different reasons, everything from, say, like anxiety and depression, right the way through to Parkinson's, frontotemporal dementia, traumatic brain injury. And Alzheimer's, and something we'll be talking about called mild cognitive impairment, are just two of those conditions. However, one of the things that I cannot sort of impress enough is that as we get older, mild cognitive impairment and Alzheimer's disease become increasingly the most common and likely cause. So if you like, the biggest risk factor is actually age. One of the other things that seems to cause a lot of confusion, and I think again, it also sort of like delays the diagnosis of Alzheimer's sometimes, is this confusion between Alzheimer's disease and dementia. So every day I see people who say, oh, I have a diagnosis of dementia. So essentially there is no such thing. Dementia is just an umbrella term. And in a way, it's a little bit like saying you've got a headache. So a headache can be for a number of different reasons. It could be for a tension headache, it could be migraine, it could be because you've had a head injury, it could be because you've got a brain tumor, all sorts of reasons why you might have a headache. The same with dementia. So dementia is just defined as cognitive impairment, so decline in those facets of cognition we've just discussed, which must be in at least two of those separate domains. It must be progressive, and it must have reached a stage where it's now impacting on what we call our activities of daily living. So that means things like going shopping or cooking or just doing sort of like normal everyday things, losing the ability to be able to do those things completely independently. And the cause of that state, so in other words, the different diseases that can result in dementia, as I said, as you get older, Alzheimer's is by far and away the most common cause. But there are, of course, other reasons as well: Parkinson's disease, Huntington's disease, vascular disease, etc. And the other thing that makes the diagnosis difficult is the fact that these symptoms develop very slowly. And as you know, anything that develops very slowly is much more difficult to identify. So there are the nebulous symptoms that develop slowly as we're getting older. And this is one of the reasons why diagnosis has become very challenging. Suffice to say that for most of the time that people actually have the condition, and we'll go into defining this, of Alzheimer's disease, they do not sit underneath the umbrella of dementia. So for most of the duration of this particular condition, someone may have Alzheimer's disease as defined by the pathological process that we'll talk about in a minute, but they haven't actually reached, if you like, the stage where their level of cognitive impairment is classified as dementia. So what do we understand in terms of what causes Alzheimer's disease? And suffice to say, this is obviously a massive topic, and I'm going to do it from a very sort of like high level for the purpose of this presentation. But there are effectively two key areas of focus, which have been very much the area of concentration for clinical research for a number of years now. There are obviously other facets to this as well, but in order to just try to keep this within an hour's presentation, the two sort of areas are the abnormal build-up of abnormal levels of something called beta amyloid and also of tau protein. So beta amyloid and tau are both proteins. They are in the brain normally, but they start to develop in slightly abnormal forms in abnormal quantities within the brain in Alzheimer's. The beta amyloid is actually sitting, it's inside the brain, but it's outside the brain cells. And the tau protein is inside the brain cells. And as a result, the brain cells are affected and ultimately destroyed by these two proteins. For some reason, it seems to target the areas of the brain where we keep our sort of cognitive cells more than any other areas, and it tends to start in the part of the brain where we have the connections and brain cells that are involved in short-term memory. That's why that tends to be one of the earlier presentations. With the beta amyloid, what happens is it gets dumped down in the brain on top of the cognitive brain cells. It stops those brain cells from working normally, and the only way the cells can respond is they essentially just shrink and die. With the tau protein, that's inside the brain cells, and it causes the brain cells to rupture, and that's the end of that brain cell. And the problem with cells in the brain is that unlike muscle cells or lots of other cells in the body, brain cells cannot regenerate. So once we lose them, we've got no way of getting them back again. If you compare that with, for example, muscle cells, where if you break your arm and you have a plaster on your arm so that you are holding the bone still by not moving the muscles, when you take the plaster off, the muscles are all thin and weedy. But when you do your physio and you exercise them, all those muscle cells regenerate and come back again. Unfortunately, that's not the case with brain cells. So it's really essential that the focus on future treatment for Alzheimer's is on preventing those brain cells from being killed in the first place. So this is just to show you slightly diagrammatically. On the left side here, we've got amyloid protein. This is normal amyloid protein. There's a little portion at the bottom of it called the A beta portion. For some reason in Alzheimer's, that becomes overproduced. It breaks off and it's floating around in the brain. There are then various factors that cause those little fragments of A beta amyloid to gather together, to aggregate and form this amyloid plaque. And then it's the amyloid plaque that gets on top of the brain cells and causes us to lose our brain cells or neurons. That gives us the neuronal loss. So and then obviously if you lose your brain cells, if you lose your cognitive brain cells, that results in the clinical condition that we've just described of dementia. So gradual memory loss to begin with, mild cognitive impairment progressing to dementia. Now, if we look at these little stars here, this is to show you how the new medications, which we're going to talk about in this presentation, work. So they work by, it's fairly straightforward. If you want to reduce the amount of amyloid in the brain in order to protect your brain cells, you need to either reduce the production, reduce the way in which the amyloid is binding together and causing this big plaque, or you want to increase its clearance. And this is exactly how these new generation drugs work. So they reduce the production, they reduce the aggregation of the amyloid to decrease the formation of the plaque, or they increase its clearance. Now, suffice to say, and again, we'll go through this in more detail, the way the drugs that are available on the market today, the way that they work is they work down here. So the nerve cells are already being destroyed in the brain, and the way today's drugs work is they effectively just help those dying brain cells to work more efficiently. to try to decrease the impact that has with respect to the amount of dementia, or the degree of dementia that an individual is experiencing. So very, very broadly, the new medications are designed to stop the brain cells from dying in the first place. And the existing medications available on the market today help the dying brain cells to function more effectively, but they can't slow down the underlying disease process that is causing these nerve cells to become destroyed in the first place. I'm going slowly through these slides here because this is really important to understanding the sort of the remainder of the presentation. Suffice to say that the tau protein, this is something that is normally inside these brain cells, and its normal sort of reason for being there is to help to stabilize the brain cells and help those brain cells to work efficiently and effectively. For some reason, that tau protein starts to take an abnormal form, and in that abnormal form, it starts to replicate itself. So this abnormal tau protein becomes more and more and more abundant inside these cognitive brain cells, to the extent that eventually the cognitive brain cell just bursts because it's got so much tau protein in it, and then you're just left with something called a tau tangle, which is just a remnant of abnormal tau protein. The way the new medications work to try to counteract this process is they work by dissolving the abnormal tau protein within the brain cells, so that instead of the brain cells becoming increasingly full of abnormal tau protein and bursting, the drug can get into the brain cell and it dissolves the tau protein, and then the brain cell just exudes that tau protein out of itself and out of the body. The other problem with the tau protein is that it can jump in its abnormal format. It can jump from one brain cell to the next, and then the whole process starts again in the next brain cell. And that's how the tau protein actually spreads around the brain. And that's why you start with just very subtle symptoms, maybe of short-term memory loss, and why gradually the symptoms become more and more and more severe and profound as more and more brain cells are affected in different parts of the brain as the tau protein is spreading around from one brain cell to the next. However, there are also new medications being designed to actually catch the abnormal tau protein as it's jumping from one brain cell to the next, and to remove the tau protein in that sort of process where it's jumping between one brain cell and the next. So not too difficult to understand that if you want to get rid of the tau protein in the brain, the way that you want to do it is either by dissolving the tau protein inside the brain cell, or catch the tau protein and remove it as it's jumping from one brain cell to the next. But these drugs, none of these drugs that have these mechanisms of action are on the market at this moment in time. This is what is being developed now to try to solve the problem of Alzheimer's disease in hopefully the very near future. But as I go through this, I'll explain how these drugs are accessible now, but I want to emphasize they're not on the market yet. There are other mechanisms as well, and I'm not going to go into those in huge detail because this is such a massive topic, but there are medications that can alter the genetic predisposition for these abnormal proteins to develop. There are drugs that can remove bacterial toxins that seem to trigger this process. There are antiviral drugs, so essentially effectively like vaccines. And there are also anti-inflammatory drugs. And there are numerous drugs being developed in these different categories currently. So what I want to focus on just for a few seconds now is what's with that. Before really understanding the role of the new treatments, I just want to explain to you what current treatments do, so that you can understand effectively where we've been and where we are, in order to understand where we're going. So the treatments that are available today, and these are the drugs that I'm sure many of you will already be very familiar with. So Aricept, which is also called donepezil, galantamine, rivastigmine. These are a group of medications which are called acetylcholine esterase inhibitors. And it actually just describes exactly how they work. So I'm just going to take you through this so that you can see exactly how these medications work. So what I've shown you here diagrammatically is, if you like, the end of one brain cell that is sending a message across to the next brain cell. And as you might imagine, as we're thinking and just doing all our higher mental function and everything that we do, that's controlled by the brain, we are sending gazillions of messages from one brain cell to the next. And this is literally millions and billions of brain cells interconnecting with each other. And the way in which they do that is they send effectively a nervous impulse or electrical impulse down through the nerve. And then that nervous impulse will trigger the release of something called acetylcholine from the distal portion of that nerve. And the acetylcholine is developed and produced inside the distal part of the nerve that is receiving the nerve impulse coming down through it with the information to send on to the next nerve. And it carries the information from one nerve to the next using this acetylcholine, which effectively is a neurotransmitter. So the nerve sends its message down, it releases the neurotransmitter, the little green dots, and the neurotransmitter carries the message from this nerve across to the next nerve. Now, everything in the body is sort of in an equilibrium, really. And there's certain times when we want our nerves firing at full blast. So we want to be releasing loads of acetylcholine, loads of neurotransmitter and sending all our messages across. But there are other times when, you just want to chill out a bit and we don't want to be firing off messages from one nerve to the next at a very high rate. And so we have something called acetylcholine esterase. And this is a chemical that just sort of like sits here and it absorbs, if you like, our spare acetylcholine. So if you want to chill out, then your acetylcholine esterase becomes super active and it absorbs all of this acetylcholine that's floating around. So if you now go over here and you imagine the scenario where you've got like lots of all these nerves all in the same sort of like bath almost in your brain, and you are losing these nerves. So it's this whole nerve that the amyloid and tau proteins are destroying. And so what's happening now is you've got fewer of these nerves. So in an area, you've got less acetylcholine to be, if you like, to use, to move, to carry messages from one nerve to the next. So what you want to do is you want to preserve your acetylcholine, your neurotransmitter, as best you possibly can. So the way to absorb, to preserve it as best you can is to block its absorption by the acetylcholine esterase. So what you do is you pop a little plug, if you like, into the thing that is absorbing your special acetylcholine, your precious acetylcholine, so that you have more of it available for transmitting your nerve impulses and your messages from one nerve to the next. And this little red thing, if you like, which is blocking your acetylcholine esterase, is an acetylcholine esterase inhibitor. And that is exactly what these drugs are. So the way that they work is they try to increase the efficiency of your dying brain cells by optimizing the use of your neurotransmitter, your acetylcholine, by blocking the thing that is absorbing your precious acetylcholine. So if you think about the brain like a bath and it's full up with acetylcholine or neurotransmitter, it's like putting a plug in the bath to try to preserve it as best you possibly can. But as you can imagine, that whole process is completely separate from the process that is causing these brain cells to be destroyed in the first place. And so that's why these treatments, the donepezil, galantamine and rivastigmine, are called symptomatic treatments, because they're just trying to improve the symptoms of cognitive impairment and dementia, but they can't stop the destruction of the brain cells, the underlying disease process of Alzheimer's. And I think this is really important to appreciate so that you can see where we're going in the future slides that I'm going to show you. So going back to the beginning, what's our goal? Our goal is effectively it's not so much to actually prevent Alzheimer's disease. Our goal is to prevent the symptoms that Alzheimer's disease causes. So it's to prevent us developing mild cognitive impairment and obviously progressing to dementia. So you don't wake up one morning with dementia. What happens is you have a perfectly normal brain, and then over a period of time, this disease process, which starts sort of like here in the sort of like center of the brain where you have your short-term memory and everything, with the amyloid and the tau protein represented as this sort of like blue stuff here, it just gradually spreads around the brain, and eventually you get to a point where there's so much disease in the brain, so much abnormal protein in the brain, that the brain now looks like this. So it's all the brain cells have been, or a lot of the brain cells have been destroyed, and the brain is what we call atrophic. So it's lost lots of its volume. And if you look at that against this sort of thing here, so there's a period of time when the abnormal proteins are in the brain, they're behaving abnormally, but the individual person is completely normal, cognitively normal. Then there's a period when they've got mild cognitive impairment, and then there's the period when clinically they're presenting with dementia. Today, this is sort of like the place where these drugs that we've just been talking about, the acetylcholine esterase inhibitors, memantine, the place where they tend to be involved is in this period here between sort of like advanced mild cognitive impairment going on to early stages of dementia. And again, that's just to try to boost cognition a little bit, to make it a bit better. So they're helping the dying brain cells to work better. The new generation medications, which is where all of the sort of research into bringing new drugs to market is over here, these new generation medications. Again, they're designed to stop the brain cells from dying in the first place. So we want to give these right up here as early as we possibly can. And these are all the things we've been talking about just now. So new medications to fight against abnormal amyloid and tau, to decrease its production, increase its clearance, decrease the damage to the brain, vaccines, etc. They should really be given up here. So anything that is designed to slow something down is obviously going to be most effective if it's given as early as possible. So there really are two game changers in this. One is these new generation treatments designed to slow further progression and to keep these brain cells alive. But the second one is being able to detect as early as possible that the disease is present. Again, if you want to give treatment as early as possible, you have to be able to diagnose it as early as possible. So this is just a little graph to sort of show you where we're at today. So on the x-axis, we're just plotting somebody completely normal, someone who essentially all the way up to this line, the individual is completely cognitively normal, as much as any of us are. Then we have this area here of mild cognitive impairment, where we are aware that we have got some very mild cognitive symptoms, maybe not quite as sharp as before, but certainly completely independent in everything we're doing. And then we cross over this critical line here, where now we start to classify as having dementia. And this is the point at which we've lost independence in activities of daily living. So what I just want to show you here is a sort of, on the y-axis, essentially, if you think of this as almost like number of people. So if this first line here, this brown line, is what happens when you just talk to somebody who's got cognitive impairment. So you maybe see your GP and you sit down and explain, you know, I'm a bit worried, my brain's not working as it should. So this can be the best doctor in the world. And what it's demonstrating is that if you have really quite significant dementia, then the doctor you talk to will sort of like 90% of the time, he'll make the correct diagnosis of Alzheimer's, because by this stage, you've got such florid symptoms that it's probably going to be reasonably easy to make the diagnosis. However, if you've got just very mild cognitive symptoms, it's almost impossible. Very few of the diagnoses made and saying, oh yes, I think this is Alzheimer's, is going to be just a tiny percentage of people. And that's because there's so many different reasons as to why you could have mild cognitive impairment, or mild impairment of your cognition. The next line up is doing really sort of like quite sophisticated neuropsychology assessments, so much more detailed assessments. And again, you can now sort of like, and obviously pretty accurately diagnose advanced dementia, But you can now see that you've got a better chance of making a correct diagnosis of these mild cognitive symptoms as being due to the underlying pathology of Alzheimer's disease. The next line up is looking at detailed MRI imaging. So it's really suffice to say if symptoms are advanced, yes, you'll pick it up on MRI. It's a fairly characteristic appearance. But when symptoms are very mild, you may not even notice there's anything abnormal on the MRI. Next one up is looking at spinal fluid. It's measuring amyloid and tau proteins. You're now going to pick up many more people correctly and accurately diagnose them at this very mild stage. The next one is looking at a type of PET scan that looks at metabolic activity in the brain, glucose activity in the brain, getting more accurate. And then we go up here to something called an amyloid PET scan. And this is actually a means by which, by doing a particular type of brain imaging scan, we can actually detect that there's evidence of abnormal amyloid protein in the brain. And as you can see now, we can pretty much accurately diagnose just about all the people with mild cognitive impairment. If their amyloid is positive, we can then say, well, yes, this is most likely to be due to Alzheimer's. Suffice to say, there may be some people in this category who have negative amyloid, and that becomes a more sort of complex diagnosis. But it's really just pointing out that we now can make an accurate diagnosis using these more sophisticated tests or more sophisticated biomarkers. And suffice to say that you can actually see evidence of this abnormal buildup of amyloid protein even before any symptoms start to develop. And this is obviously a very important area for future drug research, because obviously if we can give a treatment here that will prevent further accumulation of amyloid protein, we may well be able to either prevent the disease from developing in the first place, or at least push out the time at which it might otherwise develop. I've just popped this little circle here. This was in November 2020, so just a few months ago. There was a sort of like an interesting publication. There's lots of publications of this type coming out all the time, saying it's sort of like there's now a rapid progress towards a potential reliable blood test for Alzheimer's. And there's going to be lots of tests that are coming up all of the time to effectively find not just one of these sort of like expensive, super sophisticated biomarkers, but for a very common disease, what we really need is a ubiquitous and actually cheap biomarker that, you know, in the future, probably when we all reach about the age of 45 or 50, we can just check, do people have high amyloid and tau levels? And if so, they need to have a medication that will correct that. Just the same way as today we measure cholesterol, or we measure blood pressure, or we measure blood sugar, or any of these other indicators of underlying disease. This is just to show a picture of the part of the brain that is affected. This is looking at the brain from sort of like the front of one's face, and it's this area right in the middle here. It's something called the hippocampus, where you can see that it's normal on this side. On the left-hand side, it's small and shrunken, and that's just where there's loss of volume of that structure of the brain, and that's where we keep a lot of our short-term memory. And these images at the top here, these are just to show a picture of the brain from the side, so it's cutting through the side of the brain, and it's just showing you the picture on the edge here on your right, or yeah, my right, your left, whatever. You can just see here that the brain substance has lost a lot of its volume compared to the picture on the left of that, where you've got normal, nice, bulky, chunky brain. You can see that the brain is just sort of like atrophied, and that's due to loss of these critical brain cells due to the underlying destruction of the brain cells by these abnormal proteins. So to sort of like move, I'm going to sort of like move on almost like to the second part of the sort of presentation now. So what we really need to think about is sort of like a whole new paradigm for Alzheimer's disease. And essentially everyone is on this paradigm. So we're either completely cognitively normal and we have no abnormal biomarkers in our head, so we haven't got any of these abnormal proteins, or we can be in this what's called a sort of preclinical stage where we're completely cognitively normal, but yes, when using the appropriate sophisticated biomarkers, we can detect evidence of abnormal proteins or disease process starting in the brain. or we move gradually across and further along the continuum and across this critical midline, where now we start to develop mild cognitive symptoms, so mild cognitive impairment, and we've got actually quite a number of these abnormal proteins in the brain. Or we can go further along the line where we have sort of like, if you like, full-blown Alzheimer's dementia, where we've got a brain full of these abnormal proteins. And obviously the key thing is to prevent people in the future from even crossing this line. But most importantly today, the whole emphasis to try to slow down the rate at which one moves along this continuum. So to hopefully be able to sort of push out the time at which somebody might, someone will reach the point where they have dementia. Today, there is no drug on the market that can slow down this continuum. So once on this continuum, you just effectively progress relentlessly. I've just added here just one slide because so many people ask about this. Well, is there a genetic risk, etc. And this is in the context of my next slide, which is about risk factors for what alters the rate at which we move along the continuum I've just shown you. I have just added this one single slide just about something called apoprotein E. So apoprotein E is just one of our genetic markers, and we all get an apoprotein E gene. We have two of them. We get one from each parent, and there's E2, E3, and E4. And suffice to say that it's not completely evenly distributed, but it's not too difficult to work out that you could have any one of these combinations. Now, if you have, say, E3, you're sort of in the middle here of this continuum. And people who have E3, the estimated risk of developing mild cognitive impairment or dementia due to Alzheimer's disease through to the age of 85 is of the order of about 10 to 15%. And suffice to say that the rate of developing symptoms of Alzheimer's becomes exponential as we get older. So the rate really starts to increase, say like after about sort of like 70, 75. But if you do have a combination called E3, E4, your risk is slightly higher. And if you have E4, it's slightly higher again. About 23% of the population will have one E4 gene, and about 3% of the population have two E4 genes. So it's pretty unusual to have two E4 genes. And these are people often not, if you have E4 genes, it doesn't mean you're necessarily going to get Alzheimer's. And if you haven't got E4 genes, it doesn't mean that you're not going to get it. It's just, they're just sort of like statistical risk factors. But people who may be right up at the top end of the scale, a bit like any other condition, that they probably will have a family history where they have two or more relatives who did actually develop Alzheimer's disease, maybe in their sort of like 40s or 50s. So it is very unusual to come across families in which this is the case. And that's obviously like good news that that's very rare. The sort of, if you like, almost like the bad news is that as a condition, Alzheimer's disease in an aging population, in aging demographics, is a common disease. Hence it having been classified, as I said at the beginning, by WHO now as a global pandemic. So the answer is yes, this is very common, but the biggest risk factor is age. But yes, it is really important that we find a cure for this or a means of preventing it, apart from the personal suffering that people and their families undergo. The socioeconomic impact of this disease is obviously very considerable. So just looking at this now in terms of, again, a sort of like a statistical probability. Again, we're looking at this continuum. So, you know, having got over the fact that we're all on the continuum. So again, we're either normal, we've got mild cognitive impairment, or we've got dementia due to Alzheimer's. And the rate and probability of moving up this continuum is just related to whether you've got high or low risk factors. So high risk factors, we'll talk about them again in the subsequent studies, but this is really sort of indicating, like, you know, have you got lots of biomarkers? And I sort of like pop the sort of like genetic thing in there as well. Low risk just means, you know, you've got very few of those risk factors. So again, it's just exactly the same as any other disease or condition. I mean, think about it like diabetes or anything else. So early diagnosis in 2021, what's the point? Well, I think it's sort of like, you know, as in everything, knowledge is power. But I think here it's understanding and choice. And I think really it's important to know that, you know, like if we can make a diagnosis and that can be accurate, then there's a chance to open doors and to provide choice and opportunity to individuals who have a diagnosis. And before I sort of talk a little bit more in the latter part of this presentation about new medications, I do want to emphasize the importance of non-drug interventions as well. One of the important things, obviously, as I showed you from that big wheel at the beginning with all the different conditions that can cause cognitive impairment, is to exclude reversible causes. So it may just be that your cognitive impairment is due to anxiety, depression, all sorts of things like that. And obviously you want a diagnosis so that you can reverse those symptoms as well and as quickly as possible. It is important for caregiver education, for support, and for improved access to medical and social services to have a diagnosis. And obviously, as I'm going to show you in the next few slides, it provides you with the opportunity to get access to these new generation treatments as soon as possible. And that really is, in the end, the only way to have a chance to sort of change your outcome and improve both your own future as well as the future of future generations. So how do we change the future? That's always a tricky one. It's possible, as in all aspects of anything, through knowledge, understanding, and sort of like access. So the key components of this are early diagnosis and effective new treatments. And you might say to me, well, you know, why is this all taking so long? And you'd be absolutely right to ask that, because we probably have seen the most spectacular development of a new medication globally in the last sort of like 18 months, where a COVID vaccine has been developed from pretty much from scratch in that period of time. And literally suffice to say, that is absolutely extraordinary. And I think possibly one of the most extraordinary things that's ever happened in medicine and through clinical trials, certainly for a very long time. The development of new Alzheimer's medications is currently taking over 18 years. And the most recent of the current medications that are on the market, which are the symptomatic ones, i.e. just helping the dying brain cells work more efficiently, came on the market about 18 years ago. So it just gives you a sense of where we're at and why there's so much focus on this now. And as with the COVID vaccine, I'm afraid the answer is through international clinical trials. So as I said, there are two components to this revolution, and this is both sort of like with respect to clinical trials, but it's the biomarkers and it's the treatment. So firstly, why are the biomarkers such a game changer? So I think probably you sort of like already got this now. The reason being that the amyloid and tau can be deposited in the brain even without causing any cognitive symptoms. And we've demonstrated that from doing these fancy amyloid and tau scans. And individuals with these biomarker changes, we know now, are at risk of cognitive decline. And actually they are sort of like the excellent candidates for early intervention with disease-modifying treatments. And so essentially what the biomarker revolution has done is it's further redefined Alzheimer's disease. And what I'm going to read to you now is actually the current most up-to-date definition of Alzheimer's. And I hope from what I've explained already, this will now make total sense. So Alzheimer's disease is now defined as a biological entity defined entirely by amyloid, tau, and new neurodegenerative biomarkers, irrespective of clinical symptoms or functional decline. So it's exactly the same as saying that diabetes is defined by abnormal control of sugar. It's not necessarily defined anymore by a diabetic eye problem or vascular disease in the legs or nerve problems related to diabetes. It's all like really defined by the underlying cause of the condition. And I think this is a very sort of like very optimistic and sort of like sobering definition now for Alzheimer's disease. So we're really dealing with a condition in which there are abnormal proteins and other sort of like biomarkers in the brain, which we need to be able to detect and which we need to be able to aim treatments against even before we start to develop clinical symptoms. So early diagnosis is obviously going to empower all of us, but certainly today empowers the individual. And I do want to stress again here that there's current evidence that at least 30% of instances of dementia are actually the result of modifiable risk factors, which I'll list in a minute. But essentially to say in the non-pharmacological stable are all the sort of like healthy brain interventions that we can make. And it's never too early to start these interventions. And then there are other cognitive interventions such as cranial stimulation and various things like that, but not drugs. And then in the pharmacological arena, we have the cerebral protective agents, i.e. protecting us from developing death of the brain cells. And then obviously the cerebral enhancing agents, which once we have sort of like, once our brain cells are being destroyed, we're trying to get our brain cells to work as best as possible. So no surprises here. What are the factors in terms of modifiable risk factors that we can and should all be doing? It's diet. I won't go into that in too much detail because there's so much on the, everywhere about diet. As a general rule, what's good for your heart is good for your brain, but there are a few additional sort of things as well to be thinking about in terms of diet. Exercise is hugely important. Limiting alcohol, stopping smoking, exercising your brain. Your brain is a muscle. It's really important to keep mentally active, socializing, etc. Sleep, I think in everything is becoming increasingly important. And then just sort of like reducing stress and things like that that are bad for us. So looking after your brain is as important, if possibly not more important, than looking after the rest of your body. But if you're looking after one, you're sort of automatically looking after the other. So the sort of like 2021 conundrum, and I'm just going to give you a little bit on this before we go into some of the current clinical trials in more detail, because just when you think, okay, I got it, it actually sort of like gets a bit more difficult. But this is just something, and again, it's very topical. This is the 18th of December. It's from an American publication, and it's really a sort of like another facet of looking at Alzheimer's. But I thought it'd just be nice to put in here, particularly because it's got some really up-to-date stats. So over the past 20 years, I don't know whether this is depressing or what really, but the pharmaceutical industry spent over $600 billion trying to find potential new Alzheimer's drugs, primarily on preventing the buildup of amyloid plaques. Suffice to say that, it's like all these things, they're having spent so much on it, they're just so determined to find this, and so they are continuing. And there's lots and lots of new AD medications sort of coming down the pipeline now for clinical trials. So this Newsweek story in December 2020, this is the one in this publication here, was a Colombian woman who had an MRI scan of her brain and something called a PET scan, and it revealed huge quantities of this A-beta amyloid plaque deposition in the brain. But what was a bit puzzling was that she had absolutely minimal impairment of her cognitive abilities. So you might say, well, ooh, how does that all fit together with what you've just been describing? And that's exactly what all the brain scientists were trying to puzzle through. And actually, there have been numerous studies that do show reduction in amyloid protein burden in the brain, but doesn't necessarily show slowing of Alzheimer's. So there has actually really been quite a big sort of change in focus as well, that is obviously not quite as simple as physically removing these proteins from the brain. And there are now sort of like quite a lot of technological innovations in something called gene sequencing and molecular biology. And this is to try to work out how can it be that someone obviously has some sort of genetic setup such that even though they seem to have all of the pathology to have the disease, there's something about their genetic makeup that is protecting them against it. And in fact, the National Institute of Health have pledged $2.8 billion on Alzheimer's research in 2020. And the US Congress of Legislation for NIH to prevent and effectively treat Alzheimer's have sort of like made a pledge to have achieved, you know, like an active treatment with these new types of medications by 2025. So I think it's really just to show you this is so topical at the minute. Now, since 1998, where's all that money gone? Well, there's been 150 unsuccessful attempts to develop new medicines to treat and potentially prevent Alzheimer's. So what's next? And in this sort of, with respect to the pledge of all the sort of like money for research now. So the NIH are supporting 46 drug trials, 30 to focus on targets other than amyloid. They're identifying genes that may affect the risk of Alzheimer's, understanding what genes do and the proteins that they make, and determining how new molecular interactions differ in the brains in AD. And I think this is sort of quite interesting, like understanding the protective genetic mutation. And again, this is just a quotation from the article, which I think is quite fun. It just says, the most likely mutation seems to interfere with the ability of two key proteins to bind together, a binding that seems to be crucial for the progression of the deadly neural cascade that usually results in tau tangles and cell death. So it's sort of like everyone is all sort of like moving around the target, and it's a case of just trying to get all this to come together. So like, are we getting closer to the answer? I think it's fair to say that yes, most definitely. And here again, from that article, out of a single case report, we actually developed an antibody that might be the treatment, and we can get it into the brain. So this is one of the other problems with Alzheimer's, is that you have to get the drugs across something called the blood-brain barrier, which is very protective. It really protects your brain to get things actually into the brain. And that's one of the things that's been quite difficult as well. I think one of the other things that really is emerging as well is that, like, you know, like cancer or anything else, Alzheimer's is not simply one disease, but it's many diseases, each caused by the collapse of cellular systems crucial to health of the neurons that do all of our thinking. And genetic flaws may hasten the collapse of these cellular systems. And I'm not now just talking about the ApoE that we were talking about earlier, I'm talking about really sort of like sophisticated genetic things in all of us. And I think that this is really the key thing, is that the one thing, the powerful force bringing each one about is actually something far more universal and inescapable. It's the relentless passage of time. So as I said at the beginning, the biggest risk, way more than any sort of individual genetic things or family things or anything like that, the biggest risk of Alzheimer's disease is age. And unfortunately, we don't really understand age very well, but if you like, that's sort of where we're at. So now I'm just sort of bring us back to, you know, like real life and today. So importance of clinical trials for these new medications. And this is something that, you know, like Recognition Health are very involved in, and probably one of the most active companies worldwide in giving people the opportunity to come onto clinical trials for these new medications to try to, or designed at least, to slow down or ideally halt progression of disease and symptoms. So what do you get through the clinical trials? Well, accurate diagnosis using the most advanced diagnostic tools available globally, a chance to get access to these new medications. And this is the only chance, I don't mean through recognition, but the only way to access a medication designed to slow down progression of this disease today is through clinical trials, because at this moment in time, there's not yet one that's on the market. I think sort of like suffice to say, and I know this should be in fact very obvious, and I think with all of the info in the press about COVID clinical trials recently in the development of the vaccines, I think everyone is much, much more aware of the existence of clinical trials. So sort of like suffice to say that all medications that you've ever seen anywhere, at least legally, have all been through international clinical trials. That is the only way drugs get on the market worldwide. Huge numbers of patients participate in clinical trials worldwide. These clinical trials are almost always designed as what's called double blind. That means that the investigators and the people receiving the drug don't know whether you have been randomly distributed to taking active medication or a placebo, just like a dummy drug. Obviously, the people who are analysing all the results do know, but they don't know who you are. But you know who you are, and the investigators know who you are, but they don't know whether you're on active medication or a placebo. But everybody is managed medically in exactly the same way. Most of the studies in the later phases, which are the ones that we're involved in at Recognition, that randomized period will be followed by something called open label extension. And essentially that just means that regardless of whether you're randomized to take active medication or placebo in the first part of the study, you then go on to a further part of the study where everybody receives the active medication. And that's very much why we say there's an opportunity to get early access to a medication, either immediately if you're randomized to the active group or in the open label extension when everybody gets the active medication. But you can only get to the open label extension if you've gone through the randomized part of the study. And we now have multiple ongoing and new studies at our various Recognition Health centres for both mild cognitive impairment and mild dementia due to Alzheimer's. This is just an example of one particular clinical trial. It is a real clinical trial. And I'm really just showing it to you as a sort of explanation of how this is really a sort of like a global race. So what will happen is a pharmaceutical company will have a medication. They will open centres, clinical centres across the world. And these little red dots effectively are sort of like referring to individual clinical centres. And then the individuals involved in giving the people the opportunity to get onto these studies will give as many people as they possibly can in their country or their location the chance to get onto a study. But everyone is just competing. So the minute the number of people that the study has been powered to take, so in other words, the study will say, right, we're going to take 1,000 people onto this study because that's the number of people we need on the study. The minute that number of people have been enrolled on the study, then the study will just close worldwide on the same day. So if there's lots of people getting into the study down here, it just means there are not so many places up here. Or if there's loads of people over here getting on the study, it means there are not so many places for us to be able to give people in the UK an opportunity to get onto a study. What does participating in a clinical trial mean? Well, firstly, it gives you access to these new medications. I won't read through this because I think I've been through this several times now, but it's really just to emphasize that all these fancy drugs that we've been discussing, they're here now, you can access them now, but only through the clinical trials. What are the benefits of joining a clinical trial? The obvious one is you get early access to new potential treatments. Today, with all the sort of post-COVID problems, it does actually give you a chance to avoid some of the sort of like inevitable long waiting lists for cancer and all the other things that sort of like have been, you know, like have had to sort of like, you know, have been delayed a little bit just because of all the COVID crisis. So it gives you an opportunity to get access to expert medical care through a company like Recognition, sort of like straight away. You get continual monitoring of your cognitive and physical health, and you get access to experts and expensive tests without any costs. Nicely, your travel expenses are reimbursed. And again, someone's got to be first in line to receive these treatments and to also sort of like help with further development for yourself and for future generations of your family and other families. Here are a few facts, because I think there are a lot of myths about clinical trials, but again, I do think that the COVID studies have really sort of like focused people into the importance of clinical trials. They are essential for advancing our understanding of medicine. and improving healthcare and quality of life. Sort of 750,000+ people participated in clinical research in 2020 in the UK alone. Every medication on the market, as I said, has been through a clinical trial to test its suitability, safety, and efficacy. And new medications do change lives, and it's possible only through really big global collaboration and public engagement. And these studies that certainly that we're involved in, they're taking place all over the world. This is a little bit small print. I'm pleased to say it's pretty much almost the last slide, but I think it's important really just to say, how does it work if you do want to find out more? Very simply, you can register interest via our Cognition Health Facebook, our website, or just call our study team. And if George leads that study team, and you can say, please can I speak to George? And he'll be there. Our specialist will analyze your profile to ensure that you meet the eligibility criteria for one or more of our studies. And then obviously completely confidentially, a member of that specialist team will go through a number of questions just to make sure that, you know, one, they've placed you accordingly, and secondly, given you all of the information about that particular type of study. If you match a study, then we will obviously give you an appointment at one of our clinics, which are in central London, Birmingham, Guildford, Plymouth. And if you're listening from the US, we also have a clinic in Fairfax, Virginia, just outside Washington. When you come to your first visit, you'll meet one of our expert study doctors, myself, one of my colleagues. And the very first thing we will do is obviously to discuss everything with you, your symptoms, the treatment, what the study's about, everything, before you're in a position where we would let you, if you wanted to consent onto the study. Once we've done that, and once we've done the consent onto the study, you then effectively are consenting to going through the screening process, which determines clinically whether or not you're eligible for study. And the reason the process is very thorough is because there is no situation effectively where you can actually end up getting onto a study that isn't the right study for you. And that's obviously very important. And then you'll go through a series of increasingly sophisticated diagnostic tests to confirm or refute a diagnosis. Everybody who comes to these visits will need to bring with them a study partner. It can be their partner or a very good friend or whatever. And then if you do pass all of the screening assessments, that's the point at which you're then randomized into the clinical trial itself and you start taking the medication. So I hope that's been a helpful tour through the sort of current status in Alzheimer's. I hope you will feel like me, there's reason for sort of cautious optimism, that there's a huge amount of work going on now to develop new treatments and new diagnostic biomarkers to really move the needle for this condition. And I sort of can't emphasize how important it is, given that this has now reached a state with all our sort of aging demographics, that this is now officially a pandemic. So thank you very much, and really delighted to take any questions.
Thank you so much for that, Dr. MacSweeney. So we have actually had a few questions come through, so I'll probably pose a few to you, but I am aware that we are slightly going over time, so please just interrupt if I know your schedule is incredibly busy. But the first question we've had through was someone's asked, can head injuries cause Alzheimer's disease? I've had an MRI scan that showed I'm okay, but apparently I should have a PET scan or a lumbar puncture too. So
the answer is that, and I know there's a lot in the press about this at the minute, and this is actually another area that we at Recognition are very involved in. But head injuries, but particularly repetitive head injury, particularly in contact sports, can lead to a condition called chronic traumatic encephalopathy, CTE, which does actually invoke the whole sort of like same tau pathology that we've been talking about. And yes, it does present with symptoms of a progressive dementia. It is a slightly different scenario from the Alzheimer's scenario, but it's very difficult to tell which of these conditions you may have, particularly if you have a history of playing contact sports or you've had a head injury in the past. So my advice to you, if you're interested in this, would be to similarly to sort of contact us. And this is one of the things that we would do, is to try to work out what's the most likely cause of your particular symptoms, and then sort of like advise you in the right direction. So if it looks like this could actually be an Alzheimer's pathology, then certainly would be sensible to screen for a clinical trial. If it looks like this might be something more going down the sort of chronic traumatic encephalopathy, or it's a fixed brain injury that's occurred as a part of a big road traffic accident or something like that, we would point you in the right direction for that.
Thank you. The next question is, can I take part in your clinical trial without a diagnosis?
Yes, many of the studies that we're doing are actually for people with very mild symptoms. We do have studies for people with more severe symptoms, but many of them are for very mild symptoms. And very frequently, the diagnosis will be made during the process of the screening, when we do these sophisticated tests. And most of these very sophisticated tests actually aren't done outside of clinical trials sort of anyway, because in a clinical trial it's essential to get the absolute accurate diagnosis, because you don't want to give someone a drug that they haven't got the condition for. So yes, that's very, very common. One of the things that our pre-screening team will do is to ask various questions so that we can try and work out one, which would be the most appropriate trial, but secondly, to try and get a gauge of your cognitive, where your cognitive problems lie. And each of the clinical trials has a very specific battery of cognitive assessments that will screen you in or out according to the particular cognitive profile that specific study is looking for. And obviously the cognitive profile it's looking for is the one that the drug is most effective for.
That's great.
Sorry, there's a bit of thunderstorm going on here.
The next question is, I know we touched on this a little bit, so maybe a quick answer, but is there any evidence to suggest a healthy diet contributes to slowing the decline of memory loss?
So that's sort of like a tricky one. The answer is it's definitely better to have a healthy diet than not if you've got any symptoms of memory loss. But I think the one where the statistics are really more proven is in the context of, as a population, there is no question that healthy diet will decrease the statistical incidence of cognitive impairment. So it's slightly the other way around. So in other words, the big studies that have been done show quite clearly that healthy diet, exercise, and that's really two big ones: healthy diet and exercise done, correctly adhered to, will decrease the statistical incidence of Alzheimer's. But if you're, an individual person, you'll certainly feel better, and your cognition will certainly feel a lot better if you're following a healthy diet. And the big one, to be honest, if you want to you want to just do one or two things, it's cutting out sugars. Sugar is just so harmful for our brains, refined sugars. If you only do one thing, that's the one thing to do.
We've got a couple more questions here. The next person has said, my family tell me it's part of getting old and I shouldn't worry.
Okay, that's possibly the single biggest problem. The answer is, as we get older and maybe we're not, working all the time and things like that, the same as when you're on holiday, your concentration may not be, you might just not be concentrating as much as you do. You don't have so many deadlines to meet, etc., etc. But is it normal to start losing your cognition, losing your short-term memory, losing your sense of direction, losing your ability to do calculations as you get older? No. So everybody knows the scenario where you can have two people of exactly the same age, two 80-year-olds, for example, sitting together, One is sharp as nails, can do the crossword, can do everything, completely cognitively normal, and the other one can't remember how they got into the room. They're both exactly the same age. The answer is no, and that's actually been one of the biggest problems with the early pickup of significant cognitive impairment. So no, it's not normal to lose your memory and to become cognitively impaired as you get older.
Next lady asked, I have a history of Alzheimer's in the family on my mother's side. My mum also has Alzheimer's, diagnosed in her early 60s. I'm 35 years old and was wondering, if I wanted to get tested, when would be the most appropriate time in your opinion? Thank you.
So my answer to that is that obviously if you are concerned you've got any cognitive symptoms, then like let me know. But the most important answer to that is at a time when it's possible to do something about it, if you like. So one of the most important things is not to create a sort of like a worried well situation. My guess is that certainly by the time, you know, if you're 30, 34, 35 now, by the time you're in your, let's say, I think probably even mid-40s, I think that it's highly likely that the first of these drugs will be on the market. And at that time, it will be sensible then to sort of like, yes, to sort of think about screening or testing, because then when you get the result, there's something that you can do about it. So at the minute, I wouldn't do anything unless you really are worried that you've got early symptoms, which I think will be relatively unlikely at your age. But if you are, because apart from anything else, it's highly likely to be something else, and it's important to have that diagnosed and treated. But if you're completely cognitively fine, then I would just sort of like keep an eye to the news and things like that, and sort of be aware that there will be a time, I think probably within the next sort of like 10 years, where people maybe, as I said, in their sort of like 40s to 50s will just be screened to see if they are at risk of developing higher levels of amyloid and tau protein, and probably some other proteins that they'll have discovered between this and then as well, and have appropriate treatments.
Thank you, Dr. MacSweeney. Now we just have 3 other questions. The last one, so the one here is, do you believe that the buildup of amyloid and tau tangles need to both be tackled or can you tell which is the most serious problem for the particular patient?
I think certainly, yes, both need to be tackled. At the moment, as I said, there's no drugs on the market that can tackle them. So the only drugs are the drugs in clinical trials. And today, because they have to sort of like test one drug on its own, if you like, the clinical trials will only have one drug, if you like. So it'll be an anti-tau or an anti-amyloid. And again, the screening to get into the studies will sort of also, to a certain extent, be picking the people that either drug is most effective for. I'm only aware of one study which in fact started off as being an anti-amyloid and an anti-tau, but then it ended up just being an anti-tau treatment for various reasons. So at the minute, that's an important question, but it remains, in practice, it remains hypothetical today, but it is a very important question. And, you know, yes, I'm absolutely certain that in the future, just like any cardiology drugs or cancer drugs or anything else, you don't just have one drug, and it will be a case of, you know, you may start with an anti-amyloid treatment, then you move on to an anti-amyloid and tau. You know, it'll be a combination, and it will probably depend particularly on your specific pattern of amyloid and tau protein in the brain. Because again, it's not just one disease. Some people have lots of tau and they don't have much amyloid, and vice versa. So it will be probably relatively bespoke to the individual.
Thank you. And the final question here is, do you think it would be long until one of these medications is actually licensed?
So I mean, again, I'm sure that there are many people listening who know a lot about what's going on with the medications at the moment. There is one medication which is being reassessed by the FDA in June of this year, and that's a drug called aducanumab. And it is possible that if it gets through the FDA, that it would potentially be reviewed by MHRA, which is our equivalent of FDA. And like, I have no idea because it's not what I do, but yes, it's likely that that could potentially become available. But obviously, and I do want to put this caveat, and again, I have nothing whatsoever to do with this, but as you know, medications in the UK, in order to become accepted, if you like, and prescribed through the NHS, have to be then approved by an organisation called NICE, and they determine which drugs become available through the NHS. So a drug may be available on the market, but it might not be necessarily available through the NHS. So yeah, I mean, this isn't sort of like all completely hypothetical thinking. This is sort of like on our doorstep.
Perfect. Thank you so much for that, Dr. MacSweeney. Now, that was all the questions I've had here. I know a few people have dropped questions in just about the slides being and any recordings to be sent. We will make this recording available on our YouTube channel as well as on our Facebook page, so anybody can view that afterwards. But I've just dropped a message as well into the chat for everybody in case your question couldn't be answered today, or if you have any questions you think of afterwards, our email address or our telephone number as well to speak directly with our team of clinicians who can run through eligibility and answer any questions you may have. So thank you once again for your time, Dr. MacSweeney. It's been an amazing session. It's really informative.
Thank you.
Speak soon, guys.